Good evening, everybody. Thank you for joining us at our Breast Cancer Now Facebook Live this evening. I'm Catherine. I'm one of the clinical nurse specialists at Breast Cancer Now, and I'm one of the clinical nurse specialists for secondary breast cancer here at the organisation. And today is Secondary Breast Cancer Awareness Day. It's the 13th of October. It's the day that's traditionally been earmarked for us to raise awareness about the disease, which is basically breast cancer that has gone beyond the breast itself and the lymph nodes, the glands underneath the armpit, to other places in the body. And at that point, we know it can't be cured. So that's really important to know, and for us to be able to make sure that we give people appropriate information and support. And obviously every day that applies. So although the 13th of October has been earmarked for that day, and then here at Breast Cancer Now, we think about people with secondary breast cancer every other day of the year, to make sure that we support, we campaign, we're making sure people get as good access to treatment as possible, and all of those things. So it seemed only right that we did a Q&A, a question and answer session on Secondary Breast Cancer Awareness Day. And usually if you watch these, you'll know that there's usually a couple of us from Breast Cancer Now. But I thought it was really important that we had somebody from practice join us. So I put an ask out to the lovely nurses out there that I know that are supporting many of you out there with secondary breast cancer. And Louise in Luton said that she would join me this evening. So Louise, welcome to our Facebook Live. There's a couple of housekeeping things I should have done before I introduced you, so stay there before we start questions. Just to remind everybody, if they want to pop their questions into the chat underneath the video on Facebook, then we'll be looking to answer all your questions this evening, or as many as we can. So please do put some in there. We need some to be able to talk to each other about this evening. This is a public area on Facebook, so if there's anything that you don't really want other people to see, then you can always message us privately by doing that this evening if you want, or by doing that on a different day. Anything that we don't answer between us this evening, then I will be writing an answer to you, so everybody will get an answer of just some description. So sorry I threw you in there, Louise, before I should have done. I'm so sorry about that, but welcome, and thanks a million for joining me this evening. I just thought it might be helpful, given that this is a bit different, to ask you if you would describe your role, what you do, what that entails, because I know that all of your role is spent supporting those with a diagnosis of secondary breast cancer.
Good evening. Yes, I'm from Luton, so I look after quite a big caseload of all secondary breast cancers. So I've sort of a specialist role, sort of advising on treatments and its sort of side effects, look at sort of physical and emotional sort of support, and then I'm sort of coordinating all the care between various sort of health professionals. I obviously sit as part of the multidisciplinary team. What I tend to do is be able to track my patients, so if they come in through A&E, I'd want to be there as sort of their advocate as much as possible, either liaising with acute oncology, but also sort of there to try and educate our sort of other staff sort of within the sort of acute sector of sort of how advanced we are with our treatments for secondary breast cancer, sort of that patients aren't coming in with DNARs and things in place. They're actually got a good, sort of lengthy sort of prognosis. So I would deal with people sort of coming with acidic drains or pleural drains, or other acute things. One of my ladies has just had a hip replacement, so we have a lot of people having very normal sort of things for sort of their age and stage of life as well. But then another part of my role would be to liaise with the palliative care team and have a smooth transition sort of across and out into the community, and explore services that are there as well.
Okay, all right. Yeah, that sounds great. Have you got an idea of your caseload? Because obviously, collection of data is big on the agenda, and there's lots going on in the national audit at the moment. But have you got any idea of your caseload in Luton and the area that you cover?
I do 30 hours a week, so I do 4 days a week, and I've got about 180 patients.
180 patients.
They do. And I have got a handful of men as well, because people always think it's just females. But
absolutely.
I have some great guys on my case who are big advocates for making that aware, especially one of the youngsters does a lot in Luton to raise that awareness that it is in men as well.
yeah, it's really important to make sure that we always say people, you know, rather than just women. It is really easy to assume that it's just women that will be your patients and on your caseload. And I guess, you know, you mentioned about secondary breast cancer and the treatments that have got better. But I guess that makes a difference to those that have been in a role for quite some time. And I suppose your role is not, it's not super new, but it's not been around. You know, it's probably only the last decade or so, maybe that's. But the treatments must have made a difference to your caseload, because you will have a lot of patients who are living much longer who still need your support all through that time.
So I've been in Luton for 4.5 years now, and some of the ladies have been with me all of that time. And it's amazing the changes we've had. It's not necessarily in the first and second line treatments, but it's been in the third line treatments. And some of those have made some huge changes. And I've got patients who are, you know, living very well with these treatments. I mean, they're away on cruises and things like that and having, you know, a good quality of life. Lots of them working. You know, I'm often trying to fit people in at lunchtime or at the end of their work day, because they are living well with this, and that's, you know, part of my role to ensure that continues.
Yeah, that's definitely changed, hasn't it? Even if we haven't got the data, sort of the evidence to write that down, then, you know, the people that you will look after and support, and the people that we hear from here at Breast Cancer Now, definitely in the decade that I've been in this role, there's been a definite shift in that as well. So okay, before we have got a few questions that we did want to go through, and bits and pieces want to go through, unless people are going to give us some questions. We haven't got any questions, I don't think, at this point, but we've got a couple of comments. So Karen says, I live in Spain and there's absolutely no support outside the oncologist room, no financial support either, so I have to keep working until I'm no longer able. I can't lift heavy objects, and mentally it's so draining. I was diagnosed in June after a lumpectomy. So it sounds like Karen might have an early breast cancer there, but I suppose for those with secondary breast cancer, you know, your support and your signposts outside that oncologist's consultation is really important, and particularly with things like finance. Where do you direct your patients to for support and information to check out what benefits and what financial help might be available to them?
We're lucky with a Macmillan financial advisor within Luton itself, but obviously I work across borders, so it varies on the different areas, but we can normally do a referral out for finances. There's lots of people now working within the surgeries that are always working as like a non-prescription sort of writer, that they're also directing people across to benefits. Okay. So there's quite a wide variety, but we have written information as well in the Macmillan unit, so it can direct you to like the phone lines and things. There's also written advice on on benefits that's all there.
Yeah, I mean, Macmillan have done an awful lot in helping and supporting people with their sort of financial advice, or not advice, information and about claiming. But I know an awful lot of other nurses maybe signpost to the Citizens Advice Bureau, and obviously that's open to anybody to be able to go and ask them if they do need that type of support. So yeah, I've also got a comment from Sarah. She says, I've got secondary breast cancer, but my trust doesn't have a secondary breast cancer specific nurse. The way the trust is set up where I live, the nurses are based at one hospital and the chemo and oncologist is based at another hospital, so that makes it difficult, doesn't it, having consistency? So I don't see a breast cancer nurse and there isn't a specialist. How can I get my trust to consider this? I think really, Sarah, that's one that I can definitely put sort of answer. Breast Cancer Now, we do have, and this is how I know Louise, a secondary breast cancer nursing group. Our healthcare professionals hub is there for anybody to join, so that they get information and they get education from us at Breast Cancer Now. But by joining the secondary breast cancer nursing hub, and you don't have to be a secondary breast cancer nurse to join that group, then we can provide information and support and chat to people, meet up with them to be able to do that, but also put them in touch with others who've gone through that process of encouraging and successfully encouraging their trust to get one of those roles in. So ask your nurse. If your nurse is interested, ask your nurse to contact us here at Breast Cancer Now. She can do that probably by emailing our healthcare professional team, and there is an address on the website, or even just emailing the Ask Our Nurses. That would get to us as well. So Sarah, give her a little nudge and get her to get into contact with. So, okay. So we thought we'd just talk through some of the things that maybe your patients ask you about, and one of the things that comes up for us, and we were talking about the fact it definitely comes up for you as well, is just those questions for people. There's so much control that is lost out of this when you're on this treatment. Turn up here, have this scan this time. A lot of people want to know what they can do for themselves, and have some control, and a lot of that surrounds staying healthy, so health and well-being types of things. What sorts of questions do you get answered and asked? Sorry, and you know, how do you signpost people and answer those questions?
We're asked quite a lot about exercise and things, so we do, you know, it's known as the wonder drug. We're lucky in Luton, we can refer out to Luton Active, and they can have a subsidised session, and they can have an assessment of how fit they are now, and sort of some sessions set up. But as we say, we have people over sort of borders, so we have written information, we can explore what services are outside that, and we encourage any exercise. It might be gardening, it might be joining a walking group, but it's just staying as active as you can. We used to allow people to rest and sleep in between treatment, but now it's sort of the opposite to that we work towards. We have lots of questions on nutrition, and again we can signpost. We've got some fab new literature that's come through with new recipe books, taste change, just sort of changing sort of palate, and that long-term sort of thing of sort of eating. I mean, I think I've had text today saying, you know, I look at their blood results and say, oh, you know, your albumin looks a little bit low, so you need to eat a little bit more. And then, well, what do you suggest? And it's, you look at the proteins then, and so we can direct them, but we can send them out some written sort of literature. We do have a phone line now as well that we can refer out to people. It's not covered at amazing sort of times, but there is a dietitian at the end of that phone, and I encourage some of the ladies to actually email, because they've often done a lot of the very normal things we'd be suggesting, because they've had this for a long time. They've sort of worked quite hard and explored for themselves. So I often say email them and say you've got this far with your diet, but you're still struggling with fatigue or taste, or, you know, whatever it is that you're struggling with. So, you know, we've had a lot of results with that.
And is that a local thing that you're that helpline?
That's a national sort of one that's just come through from the World Food people. So, you know, there's a phone number that, you know, we can get available or get across to you.
So because there is the World Cancer Research Fund helpline. Is that the one that you're talking about? Or is that different? Yeah, okay. Yes, so for anybody who doesn't know, if you go to WCRF, World Cancer Research Fund, and you look at their cancer and nutrition helpline, I think it is. I've written it down once today, but I can't remember. Then there is a helpline number. It's free to use, and you're right, there are specific times, aren't there, when it's open. But yeah, lots of people have got really good support and information from them, and they are the experts in that, so it's actually great to be able to signpost people to that for further information. So yeah, physical activity and nutrition, and anything else that comes up, do you think that would fit in that sort of zone?
The sort of jabs come up sort of a lot. So obviously at the moment it's flu and COVID sort of time. So yes, please, everybody, please go for your flu jab at least. And what we try and say is, if you have a week off treatments at any point, that's the good time to have any of these things done, whether it's dentistry, immunisations and sort of thing. That's sort of your good week to try and get those in. COVID, if you can and you're eligible, this is the time to sort of get these things up to date. But lots of other people ask me about varying other vaccines that they're offered. It's just remembering no live vaccines. So when you're with your practice nurse, whoever it is, it's just checking that it's always not a live vaccine, and then we're happy with that to go ahead. Obviously, travel vaccines are slightly different, and we try and get a little bit more advice, but you tend to find your practice nurse is the best person to talk to about that.
Yeah, and that's still remaining sort of mindful, I suppose, when you're having these vaccines, depending on where they need to be put, that some people still want to obviously look after their arm. I know there isn't that evidence to say that, you know, having injections into an arm where you've had lymph nodes removed is, you know, we think it's definitely going to give people lymphedema, but it always seems sensible, and most people will choose to have that in the opposite arm, or, you know, sometimes some of these things can go in the leg as well. So having that discussion as well about those. And one thing that has been asked about us, I don't know whether you're asked this as well and what your response is just about live vaccines that are given to other people in the household. What do you get asked about that, and whether they should avoid those people, their grandchildren? There's the nasal flu vaccine, I think, that's given to children, which is live. What do you tend to say to those people?
I haven't come across that.
Okay, all right.
But no, not like other people haven't asked me that, but I would probably just think it is okay. As long as you're...
Yeah, I mean, we tend to sort of just say to check with the oncologist, but I think it's such a relatively low thing, and particularly if people aren't living in the house, but there isn't any specific advice about staying completely away. It's if you have it yourself rather than anything else. But if anybody's ever worried about that, then it would be a good idea just to check with the oncologist or pharmacist about that type of thing. So
we have lots of dental questions. So lots of my patients do have bone secondaries, so they might be on a bone strengthener, denosumab. So if you're needing any dental extraction or anything like that, please do liaise with your teams, because depending on what you're on, especially if it's an extraction, we might get you to stop your target therapy or chemotherapy for a few days before, maybe a few days after. But denosumab in particular, if you're having a full tooth extraction, it's really important that the dentist has got a 6-week gap. So if you're not sure, please get your dentist to refer into MaxVax. Okay. So then we can sort of do it in-house and sort of safely.
I think quite a lot of people do say to us that their dentists are a bit, I'm not really sure what to do. They know about denosumab and they know that the issues with that, but they're not sure. So actually being able to refer into MaxVax or a specialist dentistry, sort of community dentistry. I know we've got a session at the end of the week for the secondary nursing group on dentistry at the end of the week, and we've definitely done a speakers live for people earlier this year. So if you are living with secondary breast cancer and you want to just check out our services, then you can have a look at our Living with Secondary Breast Cancer services, and our speakers live often cover that sort of topic as well. I'm just going to have a quick look at the questions as well now, but this is not, it is about secondary breast cancer, but it's actually about signs and symptoms and worrying. I think it's important for us to answer this. It's Alison that says, I had a primary breast cancer in 2017. She's actually a volunteer for breast cancer now. Thank you, Alison. I'm worried about a strange thing in one place in my back, which is just tingly pins and needle sensation, and I'm worried what it might be. I mean, from my perspective, if Alison, if you were to ring the helpline, we'd be asking you to report that to your treatment team or to your GP to get that checked out. Assuming that you hadn't got any other symptoms, it would be really important. But if you want to just drop us pick up the phone tomorrow or drop us a line, then we can get back to you. But it might be helpful for you to ring the helpline tomorrow and for us to go through in more detail that. Obviously, the signs and symptoms of maybe having breast cancer, secondary breast cancer that's in your spine, sometimes that can produce that type of sensation, and I assume you'd be very experienced in seeing people that have got what we call spinal cord compression, which can sometimes start with these things. Obviously lots of other things can be wrong to give different signs and symptoms, but is that something that you see very much of in practice yourself?
We do see it a fair amount. So anyone from breast cancer sort of diagnosed has an open access for 5 years. So at any point, if they're worried something's come back, obviously all my patients have got secondary breast cancer. If we know they've got spinal mets, then we go through the risk factor for spinal cord compression. We give them a pathway for sort of coming into A&E. And obviously we educate A&E about fast tracking through and onto that pathway. But we're always saying if you see any change of symptoms, sort of neurological change in bladder or bowel or tingling sensation, especially going down your legs or into your feet, we would want to sort of explore that. So it doesn't matter if you had a scan a month ago or 3 months ago. If you feel that change in sensation, we want you to be reactive and sort of come in. We'd rather see you than not see you, and at least sort of be getting some advice or seeing when your next restaging scan is
definitely, because if you have that, then obviously you need to get onto a pathway to get that sorted out as soon as possible, so that there's no permanent damage done. Zoe says that she had breast cancer last February, and she's had treatment as well, but she's also been getting pain in her rib. And the same applies really, Zoe, is just getting that checked out. There can be lots of reasons for pain in the rib, especially if you've had things like radiotherapy, that type of thing. But we would always advocate that people need to tell their treatment team. Hopefully you've got the same open access as Louise's, the patients at Louise's hospital, to be able to speak to somebody and report that, so it can be checked out. And if there's anybody that's not really aware of the signs and symptoms of secondary breast cancer, then you can go to our website and have a good look there. But anything that is new, anything that is persistent, we'd always want people to, if it hasn't got an obvious cause, then we would always want people to report. So Karen says, I get more achy in the evening. I've been recently getting pain in the breast and ribs, but then I'm on denosumab monthly, so I don't know if this is something to do with it. She's off on letrozole and Ibrance as well, which is palbociclib. So obviously been treated for secondary breast cancer. I guess that's the sort of thing that people will come to you and just report back and just say
Yeah, so that's very, it is sort of some of those side effects for all three of those sorts of drugs. So it's talking to your team, it's knowing how long you've been on that denosumab, or how long you've been on sort of that letrozole if it's new. It takes a few months to settle down. Sometimes just some simple paracetamol can just sort of help with that. But if it's sort of ongoing, talk to your breast care nurse and they can have a look at what else could be sort of added in there to sort of help, or just have a look on the scans and just sort of see sort of exactly where your bone secondaries maybe are, and just seeing if there's anything there that can help. Often diet as well, we look at sort of things there that can sort of help sort of with the joints and sort of things like that. So, it's thinking of your oily fish and your avocado and your nuts and things like that sort of can sort of help that sort of too.
Yeah, and all that sort of bone health information as well. It's not necessarily joint, is it? But there's just overall bone health, particularly when you have got, if you've got secondary breast cancer in the bone and you're on the denosumab or Zanita, all of those things can sort of help to look after your bone health as well. So, not got any other questions in at the moment specifically on secondary breast cancer, but I just wondered, obviously when we talk to people on the helpline, we direct people, we've got lots of services ourselves, so as I've already said, I won't go through those, but I've directed people to our Living with Secondary Breast Cancer services page, which is on the website, and I know that you have a sort of a meeting, a support group locally as well, but where else do you support people, signpost people to, because we send them to all sorts of places. Where are the common places that you signpost your patients to for support?
I think the cancer hair care is like a brilliant one that's sort of available, because it's sort of eyebrows as well as sort of hair, and it's eyelashes, so it's sort of the whole picture. But they're very good at discussing that brave thing about highlighting or dyeing your hair, especially when you're on a long-term treatment. And I think the lady there is very good at sort of seeing what's the risk and helping you decide what that risk is and whether it's sort of worth sort of taking. But I think lots of the charities are fantastic. Future Dreams is another one that we use that has lots of online sort of sports sessions. Or if people ask me about alternative therapies, I at least think if they're going to somewhere like that, they've sort of checked out a therapist, whereas obviously in Luton I don't know the acupuncturist or sort of something that's maybe sort of helping you. We used to have more of that available, but we tend to direct people now to the wellbeing centres at the hospice, because again they've got somebody sort of in-house that they've sort of tried and tested and sort of are happy to sort of deal with cancer patients. Because I know if you go to a spa or something, suddenly you're signing in so many forms and you've paid all that money to go, and then you find you're exempt because someone isn't confident or doesn't have the understanding of looking after, again, someone with more of a chronic condition that we're looking after with these secondary breast cancers.
Yeah. And anywhere else, I was trying to think. Actually, we had a group of younger women together at the weekend. So Friday and Saturday, we had 22 women, all under the age of 45. And one of the sessions at the end, they were all sharing what they found helpful. So there were lots of things. Working with cancer came up. Future Dreams that you already said. There's the House of Hope up in Scotland. We had somebody from Scotland came and join us in Leeds. Who else did we have? Future Dreams.
Make Seconds Count. count.
Make seconds count, yeah, and we'll talk about them in a little bit. But little lifts that provide the boxes. So yeah, lots and lots of signposts for there. There's Black Women Rising, if particularly for those who come from black and ethnic minority. They've got a brilliant support network out there as well. My mind's gone utterly blank. Look Good, Feel Better. Do you have that maybe locally?
Yes,
that type of thing.
Yeah.
So lots and lots of signposts for national help, and obviously where depending on where people are, they may well have local help. So I quite often direct the people not necessarily just to their clinical nurse specialist or their breast care nurse, but also if they've got cancer information centres, they're usually a really good source of local information as well. You mentioned Make Seconds Count. It might be just useful for us to talk them over. I mean, my involvement with Make Seconds Count is through their clinical trial service, but we've talked about exercise, and I know that they've got some exercise videos and workshops that people can join, as well as yoga. But clinical trials, it's just come into my head. I presume that that does come into your patient's treatment. We know that it is a big part for some people of their treatment, and certainly is an option worth talking about. How does that work with you? Do you quite often suggest trials to your patients, or do they come asking you about it?
We get a combination. We obviously have people who are very proactive, very keen for sort of trials, but it also is a stage of their treatment. So it's when maybe we're seeing the first little bit of progression. So maybe they've done that sort of longevity, maybe 18 months or something on their current treatment, and just one little area is becoming active. And that's a good time to look at a trial, because you're actually, as well as you're going to be, but inside there's one little area. So it's not, people always think, is this like my last chance? And it isn't at all. We're actually we're not looking at phase 1 trials. That's a completely different issue. That's as I say, very much sort of towards the end. It's often like phase 2, phase 3 trials. And what we often say is go meet the trials team. We from Luton, we refer through to Sarah Cannon in London. And we just say sort of meet get the information from sort of them and sort of what's available and what we're sort of thinking of. Often our consultants have heard of trials, and if you're sort of maybe ruled out of something because of a mutation with some of the new tests that we're doing, it may be because you've had Faslodex early on, that one of the injections, it might rule you out of some of the new treatments. So that's a time to sort of maybe see if there's a trial that you'd then be eligible for, and it doesn't matter that you've had the Faslodex. So it's where we're stretching everything sort of out. But it's not for everybody. Some people love it. They love being at a trial centre and having lots of input. For others, it means a bit of travel. We're fairly lucky with where we're located. It's 45 minutes sort of into London. You get very well cared for with transport and even overnight stays if needed in between. But I think you've got to be that right person. Some people like to stay with their own oncologist and their own team. Others, it's a bit of a combination. You can go off and have the trial, but you'd still stay with us and maybe have the bone strengthener and sort of things sort of like that. So then they feel happy, they're tapped in both. We never discharge you anyway, because at some point you're going to need to sort of come back to us, but sometimes it can just delay you needing to go on to that next level of what's available sort of in the NHS. So, it's definitely got a place, but it's a place for the right person.
Yeah,
sort of
definitely.
thing.
So, yeah, I think an awful lot of people are really unsure about trials. They're thinking that they are going to be that sort of guinea pig and that sort of thing.
Yeah.
But people always get the standard, they were getting at least the standard of care, and it's not ethical to sort of be giving people placebos, so not getting any treatment at all. And we had Mel at the Younger Women's event from Seconds Crown at the Younger Women's event in Leeds as well, and she, went through an awful lot of what you'd said. But the clinical trial service, just so that people know, if they haven't got a Louise to ask about this, then they will, if you go onto Make Seconds Count website, you can book an appointment with Mel, and she will actually explain trials to you, so you can just find out information, even if a trial is not something that is relevant at this time. Obviously, where people are on treatment and it's working well, then we don't change. There are maybe other trials that they could join about with blood tests, just to be having a look at markers, or quality of life and those sorts of things, but certainly a change in treatment isn't warranted at that time. But it can be helpful to get get that information to help you think about whether a trial would be something you'd want to participate in. And as you say, lots of people join trials really very early on, after maybe their first treatment has stopped working and they've progressed. It certainly isn't something for a last option unless you're looking at, like you say, phase 1 trials, which are looking at very new drugs that can be given. But most of our patients and most of the people that we'll speak to will be on phase 3 trials, which is where a drug, about its side effects. You just want to get lots of people into the trial to see how best it works in particular situations. So lots of information about clinical trials on Make Seconds Count website. If you want to book an appointment with Mel, I know she's really busy at the moment, but if you fancy finding out, and she will do a trial finding sort of service for those who are ready to look for a trial as well. But have a good speak to Mel and get more information as well.
But definitely let your oncologist know if you are interested, because
yes,
we can actually document that and be like keeping an eye out for sort of things. Some people say it at each appointment they come to, just in case something new has sort of come out. But I think with so many new treatments available, people aren't needing the trials as much as they were in the last couple of years. So, there's a lot more option at the moment.
Yeah, and I guess, one of the questions at the weekend from the younger women is, how come our oncologists don't know of all of the trials that are out there? But, there was a comment that there were over 100 trials relevant at the moment for those with secondary breast cancer. So it really is very difficult for oncologists to know each and every trial that is out there that's recruiting and where it is and that sort of thing. And they're always sort of swapping over. They've all recruited how many people they need, so that's closed and the next one will come along potentially. So it is a moving field, so it's difficult for them to keep up with, which is why actually the service that Makes Seconds Count run is so really good and flexible to be able to have a look at those as well.
We do have a trials team within the hospital, so they'll sometimes come to our multidisciplinary team meeting, which we have on a Friday, and they'll just make us aware, or they'll send something round saying there's a new trial opening and we're looking for so many clients to sort of put forward sort of for this, or some of the trial centres will approach us sort of directly saying, have you got anybody with a certain histology and at a certain stage, for something that's looking as if it's quite exciting sort of thing, and they just need a few more sort of people to.
So if people don't know that already, it might be worth finding out whether their hospital do have a trials team and they have that set up. Obviously some of the smaller hospitals won't have that, but they will still have access to trials at some of the bigger centres. So just asking around and being your own advocate and finding that information out can be really helpful, just to set the scene and know where you are in case you wanted to know more or find out more. As well. Now you mentioned, I mentioned the biomarker, and there is a comment here, and I don't know the answer to this, so it'd be interesting to know whether you've come across this scenario. Claire says, do you know if there's any other treatment for the PIK3CA mutation if you have diabetes? The only treatment I was offered I can't have because I'm a diabetic. So we know that there are a couple of current treatments that have been added in and approved for use, alpelisib and capivasertib. So both of those are given with the fulvestrant or the Faslodex that you mentioned. But what they do is, and that's a new side effect for an awful lot of us to sort of get our heads round, is can increase people's blood sugar, which clearly isn't compatible with diabetes. So have you come across this situation in practice yourself, Louise? And if so, I'm going to presume that you would normally sort of move on to the next treatment without it being this sort of specific targeted treatment for the PIK3CA.
I think we have been using it, but we're very much working with the diabetic team.
Right.
So we're actually starting them straight away on blood sugar monitoring from day one, and and invariably they are having to go onto metformin or even onto insulin. So we are managing them as full diabetics while they're on the treatment. So we haven't ruled anybody out because of it. We've just had to very much let the diabetic team lead the way with it. We've had to have them very much involved. But I've got a lady successfully managing it as a fully diabetic insulin patient and doing very well on it.
Okay.
It hasn't ruled her out.
I guess, you know, how people's diabetes is, how well it's controlled, all factors into that. So it may be that some people, it's just not, it's not going to be a good idea for them to do that. So, yeah. Talking to your oncologist about the rationale behind that, Claire, and working with the diabetic team, and just asking a bit more about that, as Louise has said, for some people it is possible. So it would be a good idea just to go back and have that conversation, but they would be able to tell you what the next treatment would be if that's something that is not going to be available to you because it's not safe to do so with your diabetes, really. And it's all of those things in the mix, isn't it? Looking at you as a whole person rather than just your breast cancer or only your breast cancer. It's really important to take those things into consideration. I did want to pick up on palliative care. Sorry, I interrupted you there. But yeah, because you've mentioned it a couple of times, particularly with sort of referring people and that you said about a smooth transition. But when do you tend to refer people to palliative care? We know that they are so good at helping people live with their cancer, and that's what they're there for. Most people, or many people, still think about palliative care and really get worried about it because they only think about end of life. But they've got so much more to offer people and help them live well with their cancers, haven't they?
Yeah, they're absolutely brilliant. I mean, their knowledge of symptom management is just brilliant. So we've got a whole team in the hospital. So if we had someone maybe with a spinal cord compression that had a lot of pain in that interim area where they're waiting for the radiotherapy to kick in and sort of work, we might involve them and they meet them that way. In the community, we can refer it. Again, it might be that we're referring out because suddenly symptoms have needed a lot of sort of management, but it's a way of them being introduced to the umbrella of care that's offered. They again can help with the benefits, they can look at the wellbeing centre. Occasionally, just for symptom management, not for end-of-life care, we can use a hospice stay, just where someone can change that medication. Say nausea isn't under control. For some reason, it may be where a met's sitting near the stomach or something, but they can have a syringe drive and just change that medication that if you were asking the GP to get it, to prescribe it, to get it to the house, would just take hours. Whereas if you went for maybe a week or something, we could just get that to a complete correct sort of management and then get that back onto an oral medication and home again. So it's a good time to, when you're having symptoms, to introduce the care. But it may be that family needs support. It may be like a sudden sort of change. But we work very closely with our palliative care. I update them if I've had patients in who are known to them and I've seen them in clinic, then I can update them of what the latest changes sort of are, if we're changing a treatment or if we're having to, liaise with another service. We're often dealing with hepatology or some of these urology, some of these sort of other professionals in between, and it may be their issue from that's causing more problem than like the cancer itself. So there's a lot of sort of liaison, but definitely there's symptom management and the umbrella of care that it opens up to sort of out in the community with 24-hour palliative advice line numbers. If family are there at 3 a.m. and not sure how to help you with your pain, if you're known to the advice line, they can just put a call in at 3. Someone might just be able to give you advice to get you through to the morning. They can send out a GP if a GP is needed. They might just send a healthcare assistant who can just help maybe get a patient settled back into bed, and then everyone in the light of day can review that patient and their management, and if managing at home is what's sort of there, or if a care package is sort of needed. So it's a really good coordination of sort of services sort of around, but we work very closely with our palliative care team.
Yeah, they can offer so much, can't they? And an awful lot of them have sort of, daytime sort of opportunities to go in. I remember one of the very first women I met through the role that I'm doing now, who's just said, it was difficult walking through the door because the palliative care services were actually based in the local hospice, but she really needed to speak to somebody and went for some talking therapy and spoke to a clinical psychologist, I think. But actually she said, I now go and speak to them for a very short time and spend my time doing an awful lot of other things. I think she'd also had some pain control and that type of thing. So people sort of feel more confident once they have been in the care of and met the palliative care teams as to what they can offer, and that they are they're pure, at that time purely there to be able to help them live with their cancer and support them and support their families, including children, which comes up quite a bit as well. So they're a brilliant resource. Understandably, I think all palliative care teams don't work exactly the same way, so they won't necessarily work in exactly the same way as you've described, but it's worth finding out from your team about your palliative care service, and whether you could be referred, just to know or just find out what services that they do offer and what's there for if and when you need that symptom control and that support as well.
And they can do short-term input. They don't need to come in and stay sort of with you sort of for long periods of time. It may be that you've had some surgery at another hospital and you're coming back to us, but the pain isn't quite managed at that time and we need that pain managed before we can get you back onto treatment. And they come in for a short period of time and they might then give you an availability of a clinic slot, because they do lots of clinics now. So they haven't always got to be coming to your own house. So sometimes it's a nice sort of pathway of introduction, at least, to see the services that are there.
Yeah, and I suppose that one of the other things just before we finish, I was going to ask you about was just about the testing of, these, we've had a mention of PIK3CA mutations. Is that something that comes up quite a bit in routine practice now? Because we have some, these couple of targeted treatments that, will target particular mutations. So how are your patients specifically tested by that, or are they in trials, or, that type of thing? How do people find out about that? Presumably, oncologists are going to suggest that to their patients at the right time, but I think it is something that people want to know an awful lot more about, and wondering whether it's relevant to them. If you could just give us a bit of information about that, that would be helpful.
So I have all my patients on a database, and that will have your histology, which is your histology when you're maybe first diagnosed with breast cancer. You may be diagnosed straight away as metastatic, but it has that histology, and that small percentage it can sort of change. So then from that, when a new treatment comes out, we can just go onto our database and see who would be eligible. And then rather than calling necessarily everybody at that point, because we're seeing you every 3 months with a scan and a restaging, we're starting to talk to you at that point, and we'll talk about whether we would be looking for a mutation if you've got that histology. Obviously not everybody understands whether they're triple negative, ER, PR positive, HER2 so it's understanding all of which hormone receptors are involved, whether you've got the HER2 involved as well. So it's working out which one you're you've got and you're then entitled to. So obviously not everybody's going to be looking for this ASR1 sort of testing. But as you come into your next clinic appointment, we would be looking at, so even if you were stable on your scans and things, we might be saying to you, just so that we're prepared, we're going to send off this blood test to the Royal Marsden and just wait for that mutation to come back, because it takes a number of weeks to hear back sort of from them, and then that can just be on your records ready, so that we then know what the next line of treatment would be sort of available. So yeah, we are monitoring and testing.
Yeah. And then, of course, I suppose it's also pertinent to say that you might send a blood test off, but actually there isn't a mutation there, so that does, sort of rule out some of the treatments. But that's fine, because that's not relevant to, if you haven't got that mutation, then there are other things. And I think the ESR1 is something that you might do at the time that people progress, rather than as as preparation. So some people might have come across that when they've come to a point where their cancer has progressed and they're estrogen receptor positive, and they've said, now we'll send the blood test off. So there are slightly different variations in the pathway, I think, isn't there, when you would do that. But prep up front always seems a really good idea, and must be really helpful to you in practice and your oncology colleagues as well, with planning as well. So
yeah, we're definitely trying to have a bit more of a plan in place with these here, but also reassuring people that actually there are lots of other treatments still available to you. It would just be putting one in ahead if you had the mutation, but the other treatments that are there are still very good, with some very good results and things like that. So these are obviously newer ones. We've got to wait and see. I've got only a couple of people on some of these new drugs at the moment to see. They've been quite a little bit slow to respond maybe in their first scan, so lots of ladies are on live groups as well, so we're getting sort of varying feedback sort of from them all chatting to each other too. So yeah, it's interesting.
Yeah, it's an interesting thing in practice, isn't it, that you sort of have these things that are approved by, you know, the NICE or the SMC for use, although I know that the SMC have decided that they're not approving at the moment capivasertib, so that's been in the news today for anybody up in Scotland. But you learn so much more when so many of your patients are on these drugs, that they don't necessarily always fit the side effect profile or do exactly what happened in the research. And obviously you can never guarantee that treatment is always going to work, even though we got much better at tailoring treatments to these mutations and changes within the cancer. But it's good to have that you know, at our disposal when that comes, when it's appropriate for people. So yeah, so I suppose we'd say to people, ask more about, you know, if you've got secondary breast cancer, you're wondering about these types of treatments or these types of tests, it's always relevant to ask your team about that, your oncologist, or if you've got a specialist nurse as well. So okay,
let's talk it through.
All right. Well, we've been chatting for 45 minutes. I don't know where the 45 minutes has gone, to be honest with you. So I think we'll finish there. Just to let people know, obviously, Louise is in Luton, so you can't call her, but you can call us at Breast Cancer Now on our helpline 0808 800 6000. There are a few comments and questions that I haven't managed to acknowledge or to answer, but rest assured, if you're still watching, then I will send you a written response to your question, and that should be done by the end of tomorrow for you. So please don't think we're going to ignore you. We're not. But I do want to finish by saying a massive thank you to Louise for joining me this evening. It's so nice to have somebody that is working in practice alongside us. A real advantage and a real joy to have had you this evening. So we'll wish everybody good night. I'll say thank you and good night again to you, Louise. And we will see people. I can't remember when the next Facebook Live is, but we've got lots going on in October, and I'm definitely doing one on the 27th of October about clinical trials with Mel, who I've mentioned many times this evening from Make Seconds Count. So if you do want to find out more about clinical trials, please do tune in then. And we've got we end the month also with a Q&A again, so if you've still got questions, then there's an opportunity to ask us then. But for now, we'll wish everybody good night.